I'm Dr. David Morwood. I am a board-certified plastic surgeon, and this is Your Health radio and television program. Thanks very much for being here. And my next special guest is board-certified plastic surgeon, Dr. Doug Sunde.
Dr. Morwood, thanks so much for having me back.
Well, Dr. Sunde, it's a pleasure to have you here. Thanks for being here. Now, we've spoken in the past a little bit for our viewing and listening audience about the training for plastic surgery, and you completed a residency, of course, as I did. Now, once again, talk about this issue of fellowship. Now, I know you did a fellowship in cosmetic or aesthetic surgery.
Right, just like Dr. Johnson was saying, that there's different phases in people's training. There's medical school. Afterwards, people do an internship. They used to call it an internship because people actually lived in the hospital. And then a residency, again, and they used to call it a residency because people would live in the hospitals. Now the internship is the first year of residency, so those words are kind of used interchangeably. And for instance, for plastic surgery, I did 6 years after medical school. And then fellowship training is usually training one does after residency, which is just advanced training in a more narrow subject.
Okay, so Dr. Sunde, we've talked about different issues before about you're a plastic and reconstructive surgeon, so in our viewing and listening audience knows that so am I. And so we take care of injuries and we take care of cancer. And one of our most commonly seen issues in the office are people coming in wanting to look better or look younger. And in my office, and I believe in yours, one very common symptom or request that I hear is that patients wanting to look more rested. And I think it's typically, a lot of them focus on their eyes and their eyelid and their what we call the periorbital area. Now, Dr. Sunde, could we start with how you approach a patient in the office who comes in and says that their eyes look tired, but they don't feel tired? How do you go about that?
I think one of the most common things that I see people come in, they say people tell them they look tired or they look angry. And it's bothersome to people, especially if they're not tired or angry. And so most of the time when people look tired or angry, it's from their eyelids and their eyebrows. And you can even see it on little simple drawings where children use. If the eyebrows are kind of tilted down, it makes people look more angry. And if they're tilted up, it makes them look happier. If they're up too high, then they look surprised, and of course no one wants that.
So I think, Dr. Sunde, you know, for the average person on the street, they may think that they have heavy upper eyelids, and sometimes they do, but of course we need to look at the whole surrounding, what we call the periorbita. Isn't that right?
It's so interesting because one of the first things I look at is their forehead and their position of their eyebrows. And people come in, they say, no, my eyelids is what I'm interested in. But we always say that the eyebrows and the eyelids are related. Some people like me have kind of lower eyebrows, and that's more acceptable for men than for women. And as the eyebrows are down, it makes your eyelids look fuller. As you raise up the eyebrows, it takes skin out of the upper, it recruits the skin up, and it makes your eyelids look less full.
Okay, so let's start with the so-called non-invasive treatments. In my office, sometimes women and men will come in saying they look tired or they look angry, and they're thinking about Botox. Now, is that reasonable for them to think about Botox if they want to correct that sort of tired or angry look?
Botox is a great product. At first I thought people were crazy when they started injecting Botox. I thought that they'd gone off the edge. But now, after using it for many years, it's a great product. What Botox does is it paralyzes little muscles, and we're able to precisely place it so it only paralyzes the muscles we want. That helps people who have wrinkles, the wrinkles that go across in the forehead, and the real frown wrinkles right between the eyebrows. And that helps a lot. Some people talk about Botox elevating the eyebrows, and I found that it gives a mild elevation, but not too much.
Okay, so you raise an important issue, no pun intended. Oftentimes a person will think their upper eyelids are heavy or they have excess skin, but you want them to actually look at the level of their eyebrows. Isn't that right? Now, how do you go about that?
We look in the mirror together, and usually we think about there's the bony rim that forms the eye socket. And usually we think that the eyebrow should be a little bit above that bony rim. And it's a rim that everybody can feel if they just feel under their eyebrow that bony rim. And usually to look, so you don't look tired and mean, your eyebrow should be a little bit above that. And then the other thing I do is we just look in a mirror together, and I hold the eyebrow up or down. And and some of it's an aesthetic thing, how the patient would like. Some people have their eyebrows in perfect position, then we would go down to the upper eyelids.
Okay, so before we get to the eyelids, Dr. Sunde, you mentioned that it may be different for men as for women. Now, it's okay for men to have a little bit of a lower brow or eyebrow than women, is that true?
Correct, and I think it's, people would think that for some men, if their eyebrows are too high, it's feminizing. So we don't want men to look like women. We want men to look their best and women to look their best. And it's different for each sex a little bit.
Okay, so let's just say, for example, in the office that you and a patient, whether it's a man or a woman, determine that they're a good candidate to have eyebrow elevation. There's different ways to do that, or is there just one way?
Yeah, there's different ways to do it, and you and I both do it all the different ways, which is great for the patients, I think, because we can offer them the full spectrum of how to do it. For some people, we use what's called an endoscope, which is like a little telescope. It's about as big as a pencil. And we make some incisions up in the hair or right in front of the hair and go down, and through that telescope we're able to see underneath the skin and can actually free up the adhesions to the skull so that it can move and pull it up north. The harder part about that is it's hard to get it to stay in the right place sometimes, and we have to use different fixation devices if we're going to do that.
Okay, so it sounds like one of the advantages to doing an endoscopic brow lift or lateral brow lift is that the incisions are very small.
Correct.
And where do those incisions go?
Usually the incisions go, I usually put them up in the hair just a little bit behind the hairline, usually one in the middle and one in each temple. I think that some people put it right at the hairline. But they're small incisions, and the advantage of endoscopic is that it's smaller incisions. The downside is it's a little bit harder to fix in one place. The alternative way is to make an incision over the top of your head, which is called a coronal incision. And we do it within the hair so the scar is hidden. And the benefit of that is we can better fix it and hold the eyebrows just where we want them to be. The downside is it's a little bigger incision, and some people can have a little bit more numbness in their foreheads, and most people aren't bothered by that.
Right, and I know, Dr. Sunde, there's at least a couple different approaches that are sort of in between the full coronal approach and the endoscopic approach, where there's the limited forehead plasty and the lateral brow lift with a temple approach, et cetera. So I think being able to offer a patient all those different options is really an advantage.
I think that's where it comes into, everybody can get a lot of information on their own, but I think that's when it comes to, you want to go see a board-certified plastic surgeon who's an expert in this field and who can offer all the different approaches and really explain what is the best approach for each patient.
Okay, very good. Now, Dr. Sunde, I'm a little reluctant to start to discuss the upper eyelids because I'm feeling like I'm pretty self-conscious about that myself. I think I'm getting pretty ready for that operation. But anyway, so after we address the eyebrow position, we can look at the upper eyelid. Is that right?
The upper eyelids it's a great operation. I always tell people upper eyelid surgery is about what people expect from cosmetic surgery. They go to the hospital or the surgery center. Some people do it even in the office. Most people do it in the hospital or the surgery center. They are either can be sedated or go to sleep depending on their preference. Anesthesia these days with board-certified anesthesiologists is a very safe procedure in either case. We remove the excess fat and skin, and they go home, maybe sleep it off that night, and the next day they feel pretty good.
So, Dr. Sunde, you raise an interesting point. Sometimes in my office, when I tell people that we're going to sculpt the fat in the upper lid, they ask me if they're a fat person or if they lost weight, would that fullness go away? What's this business about fat around the eyeball?
Well, it's interesting. There's different fat compartments. There's 2 fat compartments in the upper lid and 3 in the lower eyelids. And the fat in the lower eyelids oftentimes can cause those big bags you can see in people. And so what we do is it's unrelated to how heavy or thin they are, not like abdominal fat, but it's just how they're born. And some people are born with more fat than others. And so we can go in and when we take out the extra skin, as you say, we sculpt that extra fat. If they have too much, we take it out. If they have it in the wrong position, we try and change the position. And if they have too little, sometimes we would even add fat in certain areas.
Right. So, Dr. Sunde, I tell patients in my office that those fatty pockets are held in place by a septum or a membrane. And in some families, that membrane or septum kind of gets weak. and it sort of protrudes through in the upper eyelid, and of course in the lower eyelid, as you said, it makes people look like they have those pouches. Isn't that right?
Oh, it's so interesting, and I think that even people in college, I can think of some great friends of ours, and the man had those big fat compartments in his lower eyelids in college. And you can see, so it's not even just an aging thing. Some people can have it and just are genetically that way, and I'm sure our people in our audience can think of friends who have big bags in their lower eyelids, and that's just how they're born, just like if they have blonde hair or blue eyes or brown eyes or whatever. And for those people, we can help them a lot, as well as people who have it more accentuated as they age.
Dr. Sunde, I think you're right. Most people associate that with a sign of aging or being tired, but really it tends to run in some families that septum or membrane just starts to get weak, and so the fat protrudes through.
Yeah, I've even operated on, typically we don't do a lot of cosmetic surgery for very young patients. But for lower eyelid fullness, I've operated on people who are even in their 20s,
Sure.
who had big bags, and I'm sure you have as well. And you take out those big bags, and they've got nice tight skin, and they've got great muscles, but they just were given those big bags, and by taking them out, it helps a lot. And sometimes we can even do that without external incisions for the lower eyelids.
Okay, so we've discussed the eyebrow position. We've started to talk about the upper eyelid. And again, in the upper eyelid, you can take away excess skin and sculpt those fatty pockets.
That's correct. And then the last thing about the upper eyelid we should talk about is the position of the eyelid compared to the pupil. Some people have so much extra skin that it blocks their vision. It just sits down like a hood. And for those people who actually have their vision blocked, the insurance will help pay for that. If they don't, then it's just a cosmetic procedure. Some people, the other thing is that their eyelid position could be lower and actually block their pupil. And we call that ptosis. Ptosis just means kind of hanging. And it can hang in front of their eyelid. And for those people, we do a different operation to try and bring their eyelid up so that they can see again.
Okay, so in true ptosis, that muscle that lifts up the upper eyelid called a levator, that can get weak, or it actually can sometimes tear off the plate, the tarsal plate in the eyelid. Isn't that true?
That's right. And then those people come in and they're often kind of tilting their head back to look, or they just can't really see, because it's not only that they have a lower eyebrow or extra skin in their upper eyelid, but it's that their eyelid position's low. And as you know, and as probably everybody in the audience would figure out now, if it's a different kind of problem, we have to have a different kind of solution for those people. So we have to identify the problem and then have a specific solution to fix that problem.
Well, Dr. Sunde, actually, I don't mind telling you and letting the audience know one of the things I admire about you is your careful preoperative analysis. In your practice, you take a lot of time, whether it's the eyelid or another part of the face or the body. You think it's important to spend a fair amount of time with the patient doing the preoperative analysis. Isn't that true?
Well, I think, of course, for both of us, and I think really for any board-certified plastic surgeon, you have to have a good plan and identify the problems to end up with a good operation.
Great. So we've talked about the brow, we've talked about the upper lid. Now again, talk some more about the lower lid if you can. We've talked about the pouches, those fat protruding pouches that can kind of start to come through that weakened septum. But again, I hear in my office, doctor, I have all this extra skin in my lower lids. Now is that true? Do people have a lot of extra skin in the lower lids?
The lower eyelids are a little bit more touchy, because I always tell people it's like your lower eyelid hangs from the bony orbit like a clothesline. And the problem is, if you put just a little extra tension on that lower eyelid, people can get their eyelids pulled down, and it's kind of like a basset hound. When they have their lower eyelids pulled down, and you can see the pink part, and nobody ever wants that. So what we're always careful to do is not take too much skin out of the lower eyelids. Some people have a little extra skin, but more commonly they have extra fat and not too much extra skin. And if you take a lot of extra skin from your lower eyelids, you're going to put a lot of tension on that clothesline, and then it's going to pull your eyelids down, and that's a problem. So it's something we specifically avoid.
Right. Now, Dr. Sunde, I know you're really good at this procedure that affects the position of the canthus, or the corner of the eye. Now, can you explain to our audience what I mean by the canthus?
When you think of the eyelid, there's the upper eyelid and the lower eyelid. And what the edges of the eyelid, where the two come together, are called the canthus. And there's like the inner canthus and outer canthus. And
Right.
There's a bunch of special words for them. but the outer canthus sometimes can get pulled down, and that can make it so your eyelid looks funny and your tears kind of roll over onto your cheek. So sometimes we have to pull that up and tighten it up, and we do that by inserting it back into the bone where it's supposed to be.
Okay, so commonly people call that the corner of the eye, right?
Correct.
There's the outside corner and the inside corner of the eye. And so you do a procedure sometimes called a canthopexy or a canthoplasty. Isn't that true?
Of course, yeah, we both would do those kinds of things, and sometimes ophthalmologists do it, but I would think that there's certain ophthalmologists who do that, and then plastic surgeons do it as well.
Now, Dr. Sunde, I know that you also, in addition to cosmetic surgery, you do a lot of reconstructive surgery, and you'll see people with cancer either of the eyelid itself or around the eyelid, and sometimes they ask you to take it out, and sometimes the patient's sent to you by the dermatologist. Can you talk a little bit briefly about eyelid reconstruction?
Well, eyelid reconstruction is just another part of, it's similar to cosmetic surgery, and I think that the two things help each other. By doing reconstructive surgery, it gives us insight how to do the cosmetic portions better, and vice versa. The reconstructive part, we want to, of course, have it look great as well. And so what we do for some people, if they don't have enough skin, we have to put more skin in, or we have to tighten it or move it, but we have to always remember, if you put too much tension on the clothesline, it's going to pull down. And some of the older patients come in with the clothesline already half pulled down to the ground anyway. So for those people, we have to tighten it up, and sometimes that can make the hole look bigger, because as we pull the clothesline up, the hole looks like it gets bigger, but then we have to patch the whole hole. If you patch the hole with the clothesline halfway down, all it's going to do is pull down further, and then that's really bad.
Well, Dr. Sunde, I certainly appreciate you coming on the program again and discussing plastic surgery of the eyelids. I know you're very experienced and you're very good at it. I sure appreciate you being here. Do you have a website or phone number that we can give out if somebody is concerned about their eyelids?
Yeah, I think the best website, of course, for all plastic surgeons is go to plasticsurgery.org. Our website is drsunde.com, and that gets you into that website. And I think that the key is to see board-certified plastic surgeons and to have people who have the breadth of experience to address these different issues for each patient.
Dr. Sunde, I so appreciate you coming on. Thanks very much. And again, I hope you are willing to come back.
Thank you very much for having me. I sure appreciate it.
I'm Dr. David Morwood. This is Your Health television and radio program. I'm a board-certified plastic surgeon, and that guest we just spoke with was Doug Sunde, a board-certified plastic surgeon as well. We're going to come right back after a very brief pause for a good cause. Thanks.